Today we're diving into a topic that can be a real headache for medical and occupational therapy students, the hand. Specifically, we're going to clear up the confusion between two classic presentations of nerve injury: the ulnar claw, the hand of Benediction. As a future occupational therapist, your ability to understand the intricate workings of the hand is not just academic, it's fundamental to your practice. The hands are how we interact with our world. They allow us to eat, they allow us to write, they allow us to work, they allow us to connect with the people we love. When something goes wrong with the nerves that control them, it can dramatically impact a person's independence and quality of life. Understanding these conditions goes beyond just passing your exams. It's about being able to look at a patient's hand and see the story it's telling you. Is the problem with the ulnar nerve or the median nerve? The answer dictates your approach to assessment and treatment. Getting it right means you can design effective interventions that help your patients regain function. Getting it wrong can lead to frustration and a lack of progress. We'll break this down piece by piece, so you can tell these two conditions apart every single time. It's a crucial skill for OTs, the masters of function. Think of yourselves as detectives. The patient's hand is the scene of the crime, the symptoms are your clues. Let's start with the laborer's nerve, the median nerve. This nerve is a powerhouse in the forearm and hand. It originates from the brachial plexus in your neck and shoulder area. It travels down the arm. It runs right through the middle of your wrist via the carpal tunnel. Think of it as the main electrical cable supplying power to many of the muscles that allow you to grip, pinch, perform fine motor tasks. Its role is so critical that any damage can be immediately debilitating. This nerve powers a huge portion of hand sensation and movement. Functionally, the median nerve does a few major things. First, it controls muscles that let you flex your wrist, flex your fingers. It innervates most flexor muscles in the forearm. In the hand, it controls the thenar muscles at the base of the thumb. It lets you oppose your thumb to the other fingers. That opposition creates the fine pincer grasp, like picking up a coin, picking up a needle. Without the median nerve, that movement is lost. Touch the tips of those fingers now. That's the median nerve. Now let's turn our attention to the other star of our show, the ulnar nerve. If the median nerve is the laborer, the ulnar nerve is the musician's nerve. It's responsible for the intricate, fine-tuned movements of the hand, especially those involving your little finger, ring finger. Like the median nerve, it also originates from the brachial plexus and travels down the arm. However, it takes a different path, passing behind the medial epicondyle of the elbow. That bony bump on the inside of your elbow we call the funny bone. That tingling shock you feel when you hit your funny bone, that's you saying a sharp hello to your ulnar nerve. The ulnar nerve's primary motor function in the hand is to control most of the small, intrinsic muscles. Hypothenar muscles, interossei muscles, medial two lumbricals. Interossei, spreading your fingers apart, abduction. Interossei, bringing them back together, adduction. Lumbricals help you flex your knuckles while keeping your fingers straight. The tabletop position. On the sensory side, the ulnar nerve provides feeling to the little finger, ulnar half of the ring finger, on the palm of the hand, on the back, dorsal of the hand. If you're holding a can of soda, the sensation on the far side of your hand is thanks to the ulnar nerve. Now let's get to the first of our two big conditions, the ulnar claw. This condition is the result of a long-standing or distal, that is, low injury to the ulnar nerve, typically at the wrist. When the ulnar nerve is damaged, the intrinsic muscles it supplies in the hand become weak and start to waste away. Specifically, the medial two lumbricals and the interossei muscles stop working properly. These muscles are responsible for flexing the metacarpophalangeal or MCP joints, and extending the interphalangeal or IP joints, which are the middle and end joints of your fingers. It's a delicate balance of power. Without the pull of these intrinsic muscles, an imbalance is created. The extrinsic muscles in the forearm, which are innervated by other nerves, like the median nerve, are now unopposed. The extensor digitorum, which extends the MCP joints, pulls the knuckles of the fourth finger into hyperextension. The extensor digitorum pulls the knuckles of the fifth finger into hyperextension. At the same time, the flexor digitorum profundus, which flexes the IP joints, pulls the middle and end joints of the fourth finger into flexion. Pulls the middle and end joints of the fifth finger into flexion. The result is a hand where the ring and little fingers are stuck in a claw-like posture, hyperextended at the MCP joint and flexed at the IP joints. A key thing to remember about the ulnar claw is that it is a posture seen at rest. Now let's switch gears. Hand of Benediction, also known as the median claw hand. This is where the confusion often starts. We're going to make it crystal clear. The hand of benediction is caused by a high lesion of the median nerve, usually at the elbow, or in the upper arm. This is a crucial difference from the ulnar claw, caused by an ulnar nerve lesion. When the median nerve is damaged this high up, it paralyzes many muscles. Flexor muscles in the forearm, then arm muscles, and the lumbricals to the index and middle fingers. So what happens when a person with a high median nerve injury tries to make a fist? This is the most important point. The hand of benediction appears during an action. It is not a resting posture. Make a fist. When you ask the patient to flex their fingers and make a fist, they just can't. The muscles needed to flex the index and middle, the lateral half of the flexor digitorum profundus, and the flexor digitorum superficialis, are paralyzed. The thumb is also unable to flex and oppose properly due to paralyzed thenar muscles. The patient is actively trying to close their hand, but only some fingers obey. The result, the fourth and fifth fingers curl into a partial fist. Those muscles are innervated by the ulnar nerve and are working fine, but the index and middle fingers remain extended, unable to flex down. Alright, let's put these two side by side. Create a mental cheat sheet. This is the core of what you need to remember. The number one, most important difference is when the sign appears. Ulnar claw, a deformity you see when the hand is at rest. The muscle imbalance is constant. Fourth finger, always clawed. Fifth finger, always clawed. Hand of benediction, a sign that appears on action. You only see it when you ask the patient to make a fist. At rest, the hand looks mostly normal. If you only remember one thing, ulnar claw, equal sign at rest. Hand of benediction, equal sign on action. The second key difference is the nerve involved. Ulnar claw, ulnar nerve lesion. Hand of benediction, median nerve lesion. This also means the location of injury is different. Classic ulnar claw, typically from a distal low lesion at the wrist. Hand of benediction, from a proximal high lesion at the elbow or above. A high median nerve lesion knocks out the forearm flexors. Index finger, affected by those flexors. Middle finger, also affected by those flexors. The third difference is the appearance of the fingers. In ulnar claw, the problem is with the fourth and fifth fingers. In hand of benediction, the problem is with the second and third fingers. Let's bring this to life with two patient scenarios. Imagine you are an OT, and your first patient of the day is Mr. Smith. He's a 65-year-old man who had a deep cut on the inside of his wrist a year ago from a kitchen accident. He comes to you because he's having trouble with his grip. You ask him to just rest his hands on the table, palms up. You immediately notice that his right ring finger and little finger are curled up, and the knuckles of those fingers seem to be bent backward. The muscles on the pinky side of his palm look smaller than on his left hand. The rest of his fingers look fine. What are you seeing? You're observing a deformity that is present at rest. It specifically affects the fourth digit and the fifth digit. This presentation screams ulnar claw. Now your next patient, Miss Jones, walks in. She's a 30-year-old who sustained a severe fracture of her humerus near the elbow in a car accident a few months ago. She tells you her hand feels weak and clumsy. You ask her to rest her hands on the table, and they look almost identical. There's no obvious deformity at rest, though you might notice the fleshy part of her thumb base looks a bit flat. Then you ask her, "Can you please make a tight fist for me?" Recognizing the difference between ulnar claw and hand of benediction is just the first step. As an occupational therapist, your real work begins after the identification. Your primary goal is to help these patients maximize their function and participate in their meaningful daily occupations, whether that's cooking, working, or playing with their kids. Your role is multifaceted, involving evaluation, intervention, and education. For a patient with an ulnar claw, you are battling against the chronic muscle imbalance and the functional limitations it creates. This often starts with splinting. A key intervention for ulnar claw is an anti-claw splint, also known as a lumbrical blocking splint. This device holds the MCP joints of the fourth and fifth fingers in slight flexion, which prevents them from hyperextending. So, let's wrap this up. We've taken a deep dive into two commonly confused hand deformities. By now, the fog should have lifted, and the differences should be sharp and clear in your mind. This knowledge is your superpower as a future occupational therapist. You've got this.